Hello, good morning.
Good morning.
Okay, so shall we start?
Yes, sir.
Okay, so today's topic is high risk pregnancy. So bit of high risk pregnancy we discussed in antenatal care topic. Okay, here we'll go briefly, but this is just an introductory class because all the high risk cases usually the important topic will be dealt separately. Okay, like some medical disorder in pregnancy, like what we did diabetes in pregnancy. Similarly, certain other high risk obstetric factors, they will be dealt separately. This is just an introductory class. Okay, so starting with the definition. Okay, so what is high risk pregnancy? As the name suggests, okay, so it is high risk means there is a likelihood of adverse outcome, okay, to the mother and or her baby, which is greater than when we compare to the general population. Okay, so when the reference population is compared with those patients with certain risk factor, the outcome will be adverse. The likelihood of adverse outcome will be more. Okay, so that is high risk pregnancy, and the incidence it ranges from 20 to as high as 40%. Okay, what is the aim? So main aim of identifying high risk pregnancies, obviously, to prevention, detection, as well as management of this factor, which can affect the health of the mother and baby. Okay, so we know that most of the pregnancy they are straightforward, okay, uneventful, but always we have to keep in mind that all pregnancy are high risk, so that we try to screen each and every patient so that we do not miss any cases. Okay, and another so let me say in another way that why we say all pregnancy are high risk, because there are certain things which we cannot predict. Okay, so most of the cases we cannot predict. Okay, so that's why we always advise the patient that there are certain danger sign. If any danger sign she noticed, then she should come to the hospital, or during the antenatal checkup we try to screen in detail. Okay, because we have to take all pregnancy as a high risk. At risk pregnancy accounts for significant proportion of low birth weight, okay, perinatal and maternal morbidity as well as mortality. Okay, but when we compare to the reference population, almost 70 to 80% of perinatal and maternal mortality and morbidity, they counts in the high risk group. Okay, so this is the quoting from the WHO. Okay, so around 15% of all pregnant women, they develop a potentially life-threatening complication. Okay, that calls for the skilled care, and some will require a major obstetric intervention to survive. Okay, so remember this figure. So there should be at least 15% of the women, okay, they develop potentially life-threatening complications. So that is quite high. Okay, so 15 out of 100, and we do not know exactly. We cannot categorize all the women under this 15%, because certain cases they are uncertain. Okay, they are unpredictable. Like when you talk about the shoulder dystocia, 50% of the cases they are unpredictable. Okay, and so forth. Okay, so what is the importance of high risk pregnancy? The importance is so that we can our ultimate aim is to decrease the maternal as well as parental morbidity as well as mortality. Okay, so when there is significant improvement in the obstetric cares, the outcome will be good. So we can look at the national figure. Okay, so in Nepal, look, in 1990 the maternal mortality rate ratio, okay, so it was 901. It's so quite high, okay, per 1 lakh live birth. Now you can see in 2016 it came down to 239. There's a drastic decline. Okay, so 73%. Okay, so decrease in the women dying in pregnancy during labor and childbirth. Okay. So patient achieved Nepal achieved the Millennium Development Goal. Okay, and still the challenge is to obtain 70 by 2030. Okay, so these are only because of rigorous effort and strategy. Okay, so once we detect the high risk pregnancy, we tend to make policies. Okay, and this policy will cut down the maternal morbidity as well as mortality. Okay, so that is the importance. Okay, so high risk high risk patient, excuse me, they require sophisticated maternal and the fetal surveillance. Okay, and in many occasions, okay, so difficult management decision in order to optimize their outcome. Okay, so let's just classify what are the high risk pregnancy. Then we will go each by one, which are very important. Okay, so it includes general or events during the previous pregnancy, some medical disorder, surgical disorder, events during the present pregnancy. Sorry, second was previous pregnancy. Now events during the present pregnancy and miscellaneous. Okay, so in general, if the patient is teenage, less than 19 years, okay, so we consider a high risk. Okay, there could be chance of CPD, less antenatal visits. Okay, we'll discuss a bit about this. And if the patient is more than 35 years, likely the patient is having some medical disorder. There are certain complications which is more common in the elderly primary as well. Okay, so age more than 35 is also high risk category. So height 145. Okay, so in Nepalese context, we can take as low as 140. Okay, as a short stature. Okay, but generally we are taking 145 centimeter as a short stature. There could be chance of CPD. Okay, because of the pelvis will be narrowing, especially most of the cases with a short stature. In parity, more than 4, high rates of malpresentation, postpartum hemorrhage. Okay, similarly unmarried mothers, so they do not come for a visit. Okay, there could be low support at home. Okay, that's why we can classify under high risk and RH negative blood group if the husband is positive. Okay, similarly events during the previous pregnancies like repeated pregnancy loss. Okay, so consecutive 3 spontaneous abortions. Okay, but in some guidelines they have quoted more than 2 spontaneous abortion. Okay, previous intrauterine fetal death or stillbirth, previous preterm delivery, or gross anomalous fetus in previous uh, pregnancy. Okay, history of suffered treatment, history of postpartum hemorrhage or retained placenta, difficult instrumental delivery or cesarean section, and macrosomic baby. Okay, so these all in previous pregnancy make the patient high risk because they are tendency to recur in this pregnancy as well. Okay, similarly medical disorder like hypertension disorder, anemia, diabetes, okay, liver disease, renal, heart disease, endocrine disease, history of certain lifestyle like smoking, alcohol, okay, drug abuse, severe malnutrition, and obesity. So all these are medical disorder. So important one we will discuss, okay, in separate topic as well. Similarly, surgical condition, previous history of pelvic floor repair, cesarean section, okay, a previous history of pregnancy with fibroid, ovarian cyst, GA cervix. These all pose the high risks. Okay, so we'll discuss briefly each one. And similarly, events during the present pregnancy, if the patient develop hypertensive disorder like preeclampsia, eclampsia, okay, bleeding during pregnancy, malpresentation, okay, CPD, means when there is disproportionate in the fetal head or fetal uh, engaging part as well as the diameter of engagement or pelvis. Okay, multiple pregnancy, similarly Riker abnormality, small or large prostate, post maturity, pre-labor rupture of membrane or preterm labor, or certain severe infection like STI, sepsis, HIV. So all these during the present pregnancy, they are usually considered high risk. Okay, and miscellaneous, if there is no antenatal care or less visit, history of blood transfusion, especially in the um, why the history of blood transfusion is important, because sometimes there are certain antibodies apart from the RS, okay, RS antigen. There are other antigen as well. So there is likely the patient may develop some antibodies, okay, which can affect the baby. Okay, that's why there could be problem during the cross matching as well. Okay, so that's why past history of blood transfusion is important. Short spacing and long spacing. Similarly, weight gain in pregnancy and congenital anomalies of genital tract. Okay, so these are the various IRIX factors. So we'll discuss the important. Okay, so what are the implications of these IRIX factors? So we'll discuss in detail about each one. Okay, so let's discuss about some starting from the general. Okay, why the young primate? Okay, so is less than 19 years. Why we consider it as a high risk? So because of the poor antenatal attendance. Okay, so usually teenage pregnant patients, they have poor antenatal attendance. Okay, and they are not sometimes at the maturity level. Okay, while we counsel, which is also a concern. Okay, so there could be problem during the education as well as screening, hypertensive disorder. So remember, not only the advanced maternal age less than 19 is also a risk factor for hypertensive disorder. Okay, so they are also likely to develop hypertensive disorder. Similarly, IUGR and preterm delivery, CPD, because there is tendency the pelvis is relatively small. It's not well matured. Okay, so it takes almost as I almost the age of full maturity of pelvis is around age 21. Okay, so less than 19 years there is tendency of cephalopelvic disproportion. Okay, when we come to aged more than 35, so with increasing age there could be increasing tendency of medical disorder like hypertensive disorder, diabetes. Okay, and other factors like chromosomal abnormality. So we can see there's increase in incidence of Down syndrome with increased maternal age and IUGR. Okay, so grand multipara, if the parity is more than 4. Okay, so there is tendency of, yes, IUGR or anemia, sometimes macrosomia, because there is tendency of being the heavy. Okay, the subsequent babies are usually heavier than the previous one. Okay, but in grand multipara, patient could be anemic. Okay, there could be short spacing, the abdomen is pendulous, so leading to the malpresentation. Okay, usually associated with hypertensive disorder. So that's why patient may develop intrauterine growth restriction, abnormal fetal presentation because of pendulous abdomen. Okay, and high risk of obstetric hemorrhage, PPS. Okay, short stature is a cephalopelvic disproportion. Unmarried, yes, they tend to receive inadequate obstetric care. Okay, so especially this they seek the medical advice late. Okay, and there is a poor attendance, so that is the concern. Why RH negative blood group is a concern? So especially if the husband is positive. Okay, so here RH negative mother. Okay, but husband should be RS positive. Okay, if the husband is RS positive, then there could be this hydrops fetalis. Okay, some congenital anemia of the newborn, or in severe form, it can cause hydrops fetalis. There could be recurrent pregnancy loss. Okay, so another is obesity in pregnancy. So BMI, if more than 30, there is high tendency of miscarriage. Okay, and fetal abnormality as well. Okay, like neural tube defect, there are more in case of obese patient when we compare to the lean patient. Okay, or normal BMI patient, because the folic acid is deficient. Okay, most of the obese women, they are deficient in some micronutrients like folic acid. Okay, also vitamin D. Okay, and operative interference. Okay, because of obesity, their tendency of prolonged labor. Okay, operative intervention, cesarean deliveries increase, chance of shoulder dystocia. Okay, so usually obese patient, there could be tendency of macrosomic baby, and it can lead to shoulder dystocia. Okay, so coming to the some surgical risks. Okay, like previous pelvic floor surgery means there is tendency of weakening of the pelvic floor, and there is tendency of prolapse. Okay, similarly previous ectopic, there is chance of recurrence and maternal anxiety. So around 10 to 15%, of the cases with previous ectopic, they tend to recur. Okay. Similarly, previous stillbirth and neonatal death. So it depends upon the cause. If it is linked with some genetic abnormality, okay, then there is tendency of recurrence. Okay. If it's a sporadic case, it may not recur. Okay. So it depends upon the cause. Okay. If it's because of abruptio, okay, there is tendency of recurrence. Okay. So it depends upon the cause. Similarly, birth weight less than 2 standard deviation. So birth weight, baby weight less than 2 standard deviation, that is IUGR, and more than 2 standard deviation, especially linked with the maternal diabetes, obese patient, or um, large baby. Okay, chance of shoulder dystocia. Okay, so it depends. So when you follow the patient, when we look at the pattern of the baby's weight, okay, it also determine if it's in the lower third, there is tendency of IUGR. If it's in the upper range, upper part of the normality, that is more than 2 standard deviation, then there is tendency of gestational diabetes, okay, shoulder dystocia, and further large baby. Okay, preterm delivery, there is tendency of recurrence. Okay, so as high as 20% is the recurrence for preterm delivery for one preterm. Okay, so for one preterm, previous history of one preterm, as high as 20%, and if there is two history of preterm deliveries, as high as 40% chance that patient will deliver preterm. Okay, they will again be preterm. So there is the consequences. Okay, so recurrence is the main issue with the preterm delivery and other consequences because of prematurity. Okay, especially consequences of prematurity, especially in case of the baby. Okay, and similarly, uterine scar. So uterine scar. So previous history of so previous cesarean delivery or previous history of myomectomy. Mhm. There is tendency of uterine rupture. Okay, because the scar could weaken because of thinning. Okay, so when there is distension, then there is tendency of uterine rupture. Okay, if the placenta attached to the previous scar, that could be placenta previa or placenta accreta. Okay, there is incidence of placenta previa in case of uterine if the patient has uterine scar. Okay, similarly peripartum hysterectomy. So these are the consequences. Postpartum hemorrhage. So if patient has previous history of postpartum hemorrhage, likely to recur in this pregnancy as well. Okay, and bad obstetric history. Okay, so most of the cases, okay, who has a previous pregnancy mishap, it can recur. Most of the, okay, so it could be any like abruptio or any recurrent pregnancy loss, shoulder dystocia, preterm delivery. Okay, most of the obstetric cases, okay, they tends to recur. So that's why we categorize them into high risk. Some lifestyle changes like smoking tends to intrauterine growth restriction, excess alcohol can lead to fetal alcohol syndrome and IVR, chronic disease. So it depends what medications he is taking. Maybe patient is epileptic and taking valproic acid. Okay, so then there is a tendency of neural defect. So it depends upon the disease and what are the prescribed medications. Drug abuse, there is tendency of sexually shared infection as well as some bloodborne virus infection. Okay, IVGR. If there's family history of diabetes, patient is prone to develop gestational diabetes, family history of anomaly, likely it can recur in the pregnancy. Okay, there is tendency of recurrence if it is linked with some genetic syndrome. Okay, and soft fertility. So there is maternal anxiety because of soft fertility treatment. There could be yes multiple pregnancy, hypertension disorder. Patient can develop PCOS. So these diabetes. Okay, especially the patient is PCOS. Patient may develop just diabetes. So these are more common in the soft fertile patient. Okay. Similarly, if the patient as vaginal bleeding during pregnancy. Okay, if less than 20 weeks, there is tendency of miscarriage. Okay, if it's more than 20 weeks, likely we have to rule out the abruptio as well as placenta previa. Okay, if when you detect the blood pressure is more than 140 or 90 during antenatal visit, tendency of preeclampsia or other hypertensive disorder is high. Symphysophonolite. So normally, sorry, small for gestation age. Okay, so it's small for death. Then there is tendency of patient developing IVGR. Okay, though the majority of the cases they are constitutionally small, but there is around 10 to 20% chance they can develop intrauterine growth restriction. Okay, similarly, large for death, then there is tendency of big baby and its complications. Why you categorize multiple pregnancy as high risk? Because there is tendency of anemia, okay, hypertensive disorder, IVGR. When you, okay, there could be selective growth restriction of one fetus, preterm delivery. Majority of the cases, almost 60-70 cases of twin pregnancy, they deliver preterm, okay, and congenital anomaly. So especially in the monochorionic twin pregnancy, there is tendency of anomaly. Polyhydramnios, so it has tendency of big baby, okay, sometimes linked with some anomaly as well as complications. Sudden rupture of membrane can lead to abruptio. Okay, so that's why polyhydramnios is also considered as a high risk. Malpresentation, obviously, there could be obstructed labor, delivery problem. Pre-labor rupture of membrane can lead to preterm delivery. Okay, so it is pre-labor preterm, pre-labor rupture of membrane. UTI. So UTI, it's very common in pregnancy. Okay, so but it is, if untreated, there is tendency of preterm labor as well as pyelonephritis, upper urinary tract infection, and leading to urosepsis. Okay, so now let's discuss how we screen for the high risk pregnancy. So we discuss general, what are the general condition which are linked with high risk pregnancy, which we categorize as a high risk pregnancy. What are the certain condition in the previous pregnancy or current pregnancy, any medical or surgical disorder. Okay, so we discuss briefly. And now how we screen the patient with high risk pregnancy. So it's basically a part of the antenatal care. Okay, so in the antenatal care also we discuss about our main aim is to screen the high risk patient, and ultimate our aim is to improve the maternal and the fetal outcome. Okay, so that's why we mainly, in every visit, we take history, we do detailed clinical evaluation, we run some tests which are pertinent to that case. Okay, apart from the routine test, and we counsel the patient, and patient education is also important part of management. Okay, so starting with the history, always is, like you say, okay, so is he a teenage pregnancy or elderly primary? Is it a primary gravida or multi or grand multipara? Okay, so priority is also important. Complaint, is he complaining of PV bleeding, okay, or headache, or any hypertensive, any suggestive feature, suggestive of any hypertensive disorder? Okay, so these are important. Always detail about the past obstetric event. Okay, so we have to form this proforma. Okay, so that's why we usually form this proforma or antenatal card during antenatal checkup. Okay, so we jot down what were the previous obstetric event: abortion or intrauterine fetal death, neonatal death, any birth defect, any preterm delivery, okay, postpartum hemorrhage, shoulder dystocia, abruptio, everything we have to document it. Okay, so because there is tendency of recurrence. Similarly, if she is having any medical disorder like rheumatic heart disease, autoimmune disorder, hypertensive disorder, okay, diabetes, because we have to optimize before she embarks on the pregnancy. Okay, so that is important. And surgical history. So we take detail. Similarly, we take detailed family history. Okay, as well as some lifestyle. Okay, some lifestyle habits like smoking, alcohol, drug abuse. Okay, this should be inquired about. Psychological concern like patient having anxiety, depression, okay, or maybe there could be linked domestic violence, major psychosocial stressors. Here we categorize these could be a high risk pregnancy because patient has a poor attendance. Okay, there could be poor support, and patient may develop, especially in the post-delivery, patient may develop people's uh, depression or psychosis, okay, and it can lead to even maternal suicide, okay. So that's why these are high risk factor. That's why mental assessment is also important part of antenatal care, okay. So that's why we have to form, okay, in detail we have to take the patient history, especially focusing on the detail about the past obstetric history, okay. So obstetric table should be detailed. So here any complications, okay, any previous pregnancy event should be documented, medical disorder, surgical disorder, any surgical history, family history, personal history, okay. So these should be stressed, okay. So remember, it should be done in every visit, not in only in the first visit, every visit, okay, in subsequent visit as well as during the time of admission as well as in the labor, okay. So examination, thorough examination is very, very important, okay. So like height, weight to calculate BMI, okay, like cardinal signs like pallor, icterus, edema, vitals, pulse, blood pressure, okay, any dental caries, okay. So dental examination, thyroid, heart and lung, breast, pelvis, okay. So it depends on the case. So usually these should be included in a part of examination for all patient, okay. And thorough obstetric examination, okay, to look for uterine size, okay, thorough obstetric examination to look for uterine size, presentation, any pelvic tumors, okay, could be lesion in the genital tract, and pelvic assessment during the labor to rule out any cephalopelvic disproportion, okay, and to decide the mode of delivery, okay, is there obvious bleeding or leaking. So that's why, so careful history and physical examination of every obstetric patient is the best way to identify the high risk patient, okay. So so please rejoin, okay. So I think the time is almost over. And investigation, so there are routine investigation and special investigation. So routine investigation we discussed in the antenatal care, okay. So there are certain special investigations, okay. So like especially we tend to do in high risk patient, okay. So first and second trimester aneuploidy screening, ideally this should be offered to all the patient